Many decompose proteins or form toxins, and some do both. Their natural habitat is the soil, marine sediments, sewage, or the intestinal tract of animals and humans, where they live as saprophytes. Why so many people are getting infected? The surge since the beginning of the 21st century is believed to be related to a combination of host and organism factors. Host factors include aging population, increase in survival of immunocompromised susceptible individuals, increase in administration of antibiotics and gastric acid suppressant agents. Organism factors include emergence of certain strain types that are more virulent due to mutations in the pathogenicity locus. Diarrhea due to Clostridium difficile infection has several unique characteristics that differ from other diarrheas. Diarrhea during or after the administration of antibiotics is usually caused by alteration of the fecal flora, resulting in decreased breakdown of small molecules and an osmotic diarrhea. Promotility action of some antibiotics, like macrolides. So when the fecal flora is altered, C. difficile can dominate over the flora and start secreting its toxins. Most cases occur in healthcare settings, but the outpatient numbers are rising. Symptoms can develop up to 8 weeks after the antibiotics are stopped. It is typically a watery diarrhea, but can be bloody sometimes 15% of cases. Fever and very high peripheral white blood cells can be seen. Snorting coke. Nah, I'm kidding. But seriously, don't do it. The causes of this infection, mainly due to administration of clindamycin and ampicillin. Also caused by cephalosporins, and recently fluoroquinolones and proton pump inhibitors. Administration of antibiotics results in proliferation of drug-resistant Clostridium difficile. That produces two toxins. Toxin A. Toxin B. Toxin A, potent enterotoxin that also has some cytotoxic activity, binds to the brush border membranes of the gut at receptor sites. Toxin B, potent cytotoxin. These toxins have glycosyltransferase activity and act by modifying signaling molecules that control various cellular functions. This will lead to apoptosis, capillary leakage, cytokine stimulation and eventually, colitis. Both toxins are usually found in the stools of patients with pseudomembranous colitis. Not all strains of C. difficile produce toxins. Most used is a stool sample for a PCR assay for the cytotoxin-producing genes of C. difficile. Less used is the enzyme immunoassay for the toxins themselves. Not used anymore is the stool culture, since it will take days to grow and many strains do not produce toxin. Stop offending agent if possible, like antibiotics or proton pump inhibitors. Treat the patients based on disease severity. The case is considered severe when white blood cells are more than 15,000 cells per millimeter cube. Creatinine level is increased by 50%. So we treat by vancomycin and give the dose orally. The case is considered complicated severe when the patient has ileus, megacolon, and hypotension. So we treat by giving rectal vancomycin and metronidazole IV. Whereas if the patient had raising lactate levels and peritoneal signs, we treat by colectomy. And if the patient didn't have any of these signs, thus his or her case is mild, so we treat by metronidazole orally. It occurs in approximately 25% of patients. Treat by repeating the initial regimen, either metronidazole or vancomycin. If the patient had greater than one relapse, then taper doses of vancomycin over several weeks. If patients had multiple relapses, give fidaxomicin. It has a 30% lower relapse rate than vancomycin. Patients that a relapse would be devastating due to comorbid disease like ICU patients. Also treat with fidaxomicin. If a patient had severe recurrent C.difficile colitis, fecal microbiota transplantation would be the best solution. A highly successful procedure. Yes, after all, poop turns out to be a drug. Hand gels don't prevent transmission because they don't kill the spores of C. difficile. Only hand washing will prevent the spread. Isolate patients with C. difficile diarrhea in a private room, and place them on contact precautions. All who enter should wear gowns and gloves. Even those who doesn't examine the patient should use precautions, since the spores are found on various surfaces throughout the patient's room.